Dear friends, thank you very much for inviting me and especially the organizing committee. It's really a pleasure to be with you, unfortunately in virtual session, but I'm sure next year we will be together and it will be fun. Um, I will be a little bit disappointed when I receive the subject and the title of my presentation because I didn't know if I have to treat this presentation as a surgeon or as an onco-urologist. I mean, if I have to make a technical presentation or a more general vision presentation, and it is the last version that I did to do with you and to share with you. So to start, I would like to share with you this SEER database published in 2008 and showing the percentages of patients having RCC according to the extent of disease at diagnosis. And you can see that the percentage of patients with locally advanced RCC, which is the subject of my presentation, is about 20%. So this is the data published in the Journal of Clinical Oncology in 2008 and 4, a little bit old, but very interesting. It was done by the UCLA team. And in the figure A, you see the overall survival of patients with localized RCC according to the risk factor. I mean, low risk, intermediate risk, or high risk. And in figure B, you have exactly the same, but for patients with metastatic RCC. And for example, if you are looking for patients at 24 months, at 2 years, you have the overall survival for patients with localized RCC is 70%. And for patients with intermediate risk metastatic RCC at 2 years, the overall survival was in 2004, 40%. Obviously, at this time, we didn't have the fantastic drugs that you have today. And we know that we have a lot of drugs for treating patients with metastatic RCC, including the combo nivolumab plus ipilimumab after the Checkmate 241 trials. This publication shows for you the overall survival for patients according to the IMDC risk factors. And on this slide, I put the two IMDC risk factors in the Checkmate 241 trial. This is overall survival. So this is for intermediate risk group patients. And on the left side of the slide, I put these extremely recent publications in European Urology, which was published 2 days ago, and which shows the overall survival for patients treated for localized or locally advanced RCC, so non-metastatic one, absolutely. And it is the Philadelphia team from Bob Uzo. And you can see here the different curves. In black, it's patients with low risk. In blue and red, patients with intermediate risk. And in green, patients with high risk. And if you are looking at 2 years, the overall survival is 70%, exactly the same than the one published in 2004. But if you are looking for patients treated with Nivo-EP, patients with intermediate risk group, the overall survival is exactly the same at 2 years, 70%. So that means that locally advanced RCC, which is a high risk RCC, is a very bad disease. And the 2-year overall survival is 70%, equivalent for patients with locally advanced high risk RCC and for patients with intermediate risk metastatic RCC. So that means that in about 15 years, we have absolutely no improvement for these patients with locally advanced high risk RCC, and we have a huge improvement from 40 to 70% in 15 years. So why we have this difference? Probably because the theory is different than the reality. In theory, for patients having an advanced locally RCC, we have patients with a T3 or T4 RCC without metastasis. But in reality, what about the end status? I mean, you have lymph node. Do you have to consider this lymph node has just locally advanced local development of the disease, or metastatic? Depends the size, depends the number. Sometimes you have just 2 or 3 lymph nodes. Sometimes you have a very important mass, so probably different. But really, the reality is that you are supposed to be a locally advanced disease for patients with lymph nodes and not metastatic. What about small long nodules? You have plenty of patients having an RCC, and on CT scan on the lungs you have small nodules. Nobody knows how we have to consider these patients as metastatic, or just it is some nodules which disappear after the RCC treatment. And do we have to consider with the same value a patient with a 5 centimeter ESUP4 RCC, which is supposed a T2, versus a patient with a 12 centimeter ESUP2, which is supposed a more important tumor, but ESUP2. So it's very difficult, really, to know exactly preoperatively what sort of patients that you have to operate. There is certainly a lack of precision, and certainly in the future we will have to correct this fact. For example, this man, 67 years old, hematuria, he had a left radical nephrectomy. It was a CCRCC, no evidence of disease at 3 years. Controversially, this female, 59, anemia, she has a huge tumor, she has a left radical nephrectomy, it was a CCRCC, but she has, unfortunately, a progression at 3 months. And what about these patients? A male, 65 years old, hematuria, he has an important renal tumor on the right side, and small renal tumor on the left side, and IVC thrombosis. So we decided to make a surgery. It was a CCRCC of 10 centimeter, ESUP4, with a rhabdoid contingent, involvement of sinus fat, involvement of vena cava, and the stage was PT3 and X. And fortunately, he had long meds at 3 months. So the preoperative management of these patients is very important, because we have to make very careful clinical examination, laboratory test, CT scan, RMI, etc. And in my institution, we are doing again a CT scan or an RMI 2 days before the surgery. We can use nomograms, classification, whatever you want. The objectives is first to confirm the status, and we are supposed to operate patients with no metastasis or oligometastasis. These patients are supposed to be amenable to surgery and potentially curative surgery. Obviously, we have to discuss every case in MDT. But the reality is that we don't have, unfortunately, validated criteria, no validated classification, no validated nomogram to determine the preoperative status, to know if we have good or bad patients to operate. This is a very difficult surgery, meticulous, complex, risky, and we have really to do our best to remove this tumor with an extension on the vena cava that you see here, after the surgery with a stitch on the vena cava. It is really a difficult surgery. And this publication confirmed what I said. It was published in European Urology Oncology in 2019, showing 2,664 cases of patients with radical nephrectomy with inferior vena cava thrombectomy reported by 573 institutions. It's a very important series. And you see here on these curves that you have different overall survival according to the number of cases operated in the institution. The endpoint of this series was to observe what about the future of the patients according to the volume of patients treated in the institution. In orange, you have a high volume, and high volume was defined by more than 3. In blue, intermediate, and in red, low volume. And again, if you are looking at 24 years for patients having an operation in a high volume, the survival is 70% at 2 years. Exactly the same. So really, we have to look on neoadjuvant therapy. Today, there is no recommendation. We know that the primary tumor has downsizing reduction of 10 to 30% with TKI. We don't know exactly with immunotherapy, but some data seems to have an interesting decreasing of the tumor, especially if you are using a combo. There is a minimal effect on RCC with inferior vena cava thrombi, and the reality is that there's a lack of published large series versus control. So the future, and we hope that we will have some very interesting data from the clinical data trial trying immunotherapy alone or in combination. To my knowledge, there is 9 trials at the present time which are ongoing. Concerning adjuvant therapy, we know that there is just the extract trial with concern sunitinib, and there is one recommendation by the FDA recommended sunitinib for the very high risk patients. We know that the Assure, Protect, Atlas, Horizon, all the study in adjuvant therapy were negative. And we have clinical trials with immunotherapy alone or in combination. I think there is 4 to 5 trials ongoing, and we hope that in the future we'll have some interesting data. So I'm sure that the future is in the sequences, but obviously we have to have biomarkers. I'm not sure that the classification using only usual laboratory tests and usual clinical items will be sufficient to determine what sort of patients have to have a surgery and what sort of patient what to have a treatment before. But certainly the future will be in the sequence: medical treatment before surgery, medical treatment after surgery, or another situation will be the sandwich situation, in which the surgeon is between 2 sequences of treatment. We don't know. We'll have the results in the future, but I am sure it is the future, because we really have to improve the overall survival for these patients. Again, the surgeon do what they can do. They are doing the best, but really, according to the data I've shown, it's not good. It's not good enough for the patient 70% at 2 years. So this is my conclusion slide, a little bit philosophical, but I think it's interesting. When it is obvious that the goals cannot be reached, don't adjust the goals, adjust the action steps. Thank you so much, and see you soon. Bye-bye.